Yeah, live.
Good evening. Welcome to yet another episode of AIOS Difficult Patient Series, Walk-in Difficult Cataract Patients, How to Diagnose, Triage, and When to Refer. This webinar is being chaired by Dr. Harbansh Lal, who is the President of All India Ophthalmological Society and Director of Delhi Eye Center, New Delhi. He is also the Co-Chairman of Department of Ophthalmology, Sir Gangaram Hospital, New Delhi. Moderators would be Dr. Manoj Mathur, who is the Honorary Treasurer of AIOS and Senior Consultant at Swaroop Eye Center and Medivision, and Dr. Anand Saxena, who is the Director of Sri Aurobindo Netralaya, Raipur. Our expert panel consists of Dr. Partha Biswas, who is the Vice President of AIOS and the Medical Director of Trinetralaya, who is the Director of Netralayam as well, Kolkata. Dr. Suresh Pandey, who is the Director and Chief Eye Surgeon of Suvi Eye Institute and LASIK Center, Kota. Anaga Herur, who is the member of ARC AIOS and Medical Director of Anil Eye Hospital, Mumbai. We also have Professor Arvind Moria, who is Head of the Department of Ophthalmology at AIMS, Hyderabad, and Dr. Deepak Mishra, who is member of ARC AIOS and also Professor at the Regional Institute of Ophthalmology, Banaras Hindu University, Varanasi. We have an array of speakers. To begin with, we have Dr. L.C. Madharia, who is the Director of Ashirvad Eye Hospital, Bilaspur. He'll be speaking on phaco in traumatic cataract, a video presentation. He'll be followed by Dr. Deepak Megur, who is the Director of Megur Eye Care Center, Bidar, and he will talk on cataract surgery in small pupils. Dr. Harshvardhan Gupta, who is the Medical Director of Om Netra Kendra and Laser Vision, Raipur, will speak on management of Argentinian flag sign in white cataract. Dr. Rakesh Shakyaf, Head of the Department of Glaucoma and a consummate cataract surgeon from Sadhguru Netra Chikitsalaya, Chitrakoot, will speak on management of cataract with zonular weakness. Raghav Malik, Consultant of Cataract, Cornea and Refractive Surgery, Center for Sight, New Delhi, speak on utility of flags in complicated cataract surgery. This webinar is supported by Allergan. Welcome to the webinar. I request Manoj and Dr. Anand to take it forward.
Yeah, good evening, everybody. Let's get on with our first speaker. I would like to invite Dr. L.C. Madharia.
He has not joined yet.
Yes, no.
We can start with, I think, Raghav is ready. So we'll start with Raghav, and by that time, he'll join.
Okay, sir. Is my presentation visible?
Yes, Raghav. And Raghav
Yes.
is a consultant, as I said, at Center for Sight, New Delhi, and he'll speak on flags in challenging cases.
Thank you, sir. Thank you, Chairman, moderator, and the expert panel for having me on this exciting webinar. I will be speaking on flags in difficult situations. Okay, so let us start by looking at what a femtosecond laser is. So femtosecond laser has been used in ophthalmology for the past many years. First, not only just not the cornea, but yes, now even for cataracts. So yes, what essentially a femtolaser is doing is making a small 1 micron size mycoplasma bubble inside the structure where it is falling. This has been utilized in the cornea to make a flap or to make a lenticule. Now we are using the same technology to make cavitation bubbles within the cataract, that is within the lens, to emulsify or make quadrants in the nucleus before we go in with our phacoemulsification. So like I said, that's how our phaco or the femtosecond laser works. A complete cut can be made. It works like a zipper lock mechanism. That is, it makes very small punctate opacities or very small punctate interruptions in the tissue so that it can be torn apart easily. So femto is being used as a tool to not only for the routine, but also to simplify challenging cases. So the role of the femtolaser in cataract surgery is to make it akin to a refractive procedure. Nowadays, a patient is not coming into the OPD looking just for removal of the cataract, but the patient wants vision as a young eye, or if maybe even better. So the patient not only wants clarity in the vision, but also wants freedom from glasses. So that is how femtosecond laser is helping us. So it is helping us in essentially 4 parts. That is, one is the capsulorhexis, making the rhexis. Second is lens fragmentation, incisions, and also an astigmatism management. In my routine practice, what patients, when they ask me why should we go in for a femtosecond laser, so my go-to counseling tactic is usually I tell the patient that if imagine you are in a war, right, and if you want to fight with your enemy, what is safer? Would you want to go in with a small knife and go towards the enemy line and kill him, or would you want a sniper do that for you? So the femtolaser essentially is acting like a sniper for you. It is doing the essential part of cataract surgery before you go into the surgery. So it acts like a sniper for you and acts like a shield. So I'm going to discuss about 4 to 5 cases, how femtosecond laser technology is helping us in these complex cataract cases. Let me start with the posterior polar cataract. We all know it's how difficult it is for any surgeon, no matter how experienced. Our group has done immense work in posterior polar cataracts. So femtosecond is helping us in 4 major parts during the cataract surgery of a posterior polar cataract. One is it helps us making a very good cortical cleavage. Given the small size of the incision bubble created by the femtosecond laser, we can have a very good hydro pneumo dissection. So essentially eliminates the need of a hydro procedure. We know a hydro procedure in a posterior polar cataract can cause a posterior capsular rupture. So we are essentially eliminating a hydro procedure, and also it forms, it emulsifies the nucleus before we go into the eye. So essentially the phaco power is also reduced, hence the turbulence inside the anterior chamber is reduced. So another added advantage is the ASOCT that we have inside the femtosecond laser. I'm talking about the catalyst. I have no financial interest, but yes, it has a high definition ASOCT and it can give us a detailed picture of the lens and the cornea before we start using the cataract, before we start using the femtosecond laser on the eye. Let me start by showing a video. So if you see this video, so once the patient is docked, you can see here the polar opacity. And once we have docked the patient, we can see the posterior capsule and also you can see the irregularity of the posterior polar plaque. This means that yes, we can expect some danger during the cataract surgery. So these 3 dots, the pairs of dots that you see, what we can do is we can essentially adjust the offset of the posterior range of firing of the laser, so that the laser fires not close to the posterior capsule, but much above. So we are going to have a cushion of at least 800 to 1000 microns, so that you see the pink part, that is where our laser will fire and give us a thick cushion so that it protects the posterior capsule. That really helps us. I will show you in my further videos how that helps us. So we have done immense work and we have found that using the femto laser not only helps us do the cataract surgery in a posterior polar, but also increases the safety. So if you see this video, very clearly is the posterior polar cataract showing an equator to equator pre-existing dehiscence in the posterior capsule seen in the slit lamp. Once we dock the patient to the femto, you can see how there is a discontinuity on the posterior capsule, and because of this, we can expect challenges during the cataract surgery. While the femto is being fired, you can see we are increasing the offset so that 1000 microns epinuclear cushion is left between the epinucleus and the posterior capsule. Of course, I won't show you the laser part, but let's go into the OR. You can see that this is the anterior segment OCT integrated to the microscope. We can see that there is a discontinuity on the posterior capsule, showing that yes, we are going to face challenges. So this is again the same image of the posterior pole. So if you look at this, essentially what we've done is with the femto, you look at this thick epinuclear cushion. So we have essentially made a new posterior capsule. So the posterior capsule is safe, but the epinuclear cushion protects the posterior capsule from these turbulences. So essentially, if there is a pre-existing rupture, there will always be a rupture, but yes, we can save a nucleus drop, which is the most dreaded complication in a posterior polar cataract. So you can see that there is definitely a defect, which we could see, but yes, that epinuclear cushion helped us not have a nuclear drop. You can see that the posterior capsule showing a bulge of the vitreous, showing that the case was completed successfully with a lens in the sulcus. This is the same image showing different types of posterior pole, same case showing us how the posterior capsule appears. This is on the slit lamp. This is on the microscope integrated ASOCT showing a discontinuity of the posterior capsule. This is the swept source ASOCT of the IOL master, and this is the intraop OCT after the removal of the cataract. You can see that the posterior capsule is intact, and this is the vitreous blob which is not damaged, so that the vitreous is not, there is no disturbance of the vitreous, and the lens can be placed in the sulcus safely. So epinucleus is essentially acting as a shield. So I might want to ask you, if you're sitting in a car, what car would you want to sit in? A car that has no airbag or a car that has an airbag? So the next case I'm discussing is a small pupil. This is another case where we used a Malyugin ring before we used the femtosecond. So the patient had to go to the OT thrice, but it was advantageous. Once we make the main port, we can inject the Malyugin ring through the 2.2 millimeter incision. The Malyugin ring, of course, gives us a good round pupil. And once that is done, we can shift the patient under the femto laser. And you can see this is the Malyugin ring in place, and the femto laser is firing, gives us a good sextants. And then once that is done, definitely surgery is much more easier. Another case I would discuss is that in a phacomorphic glaucoma. Yes, we know that in a phacomorphic glaucoma, the anterior chamber is very, very shallow. And doing a cataract surgery in such a case can cause lots of complications. So in this case, what we do is we go in with the femto laser, and the best part is that we can, of course, make a rhexis. That is the most important part. Despite the high vitreous pressure, we can see that a rhexis is being formed within a second. And you can see that boom, we saw that was because of the intralenticular pressure that was suddenly released after we made the rhexis. And once the rhexis is made, the other part of the surgery is definitely much more easier once the pressure is relieved from the lens. And then, of course, we can go ahead and make chops inside the nucleus, and then a lens can be implanted. Flax definitely has an advantage in hard rock cataracts. So if you see this is the grade 5 cataract, we can make customized rhexis of 5.5 millimeters or 6 millimeters even if you want that. And you can see those small air bubbles coming in through the chops in the nucleus, and you can see the hardness of the cataract. Yes, the main advantage is that we are using the femto laser energy to compensate for the ultrasonic energy which we might have required, one for breaking up the nucleus, and then secondly to emulsify the pars. So essentially 30 to 40% of the phacoemulsification power is reduced. The last case I will talk about is a post-traumatic subluxation. This is a doctor that came to us after an RTA. You can see that the nucleus is decentered very much, and we have also published this, that we use the femto laser. The main advantage is that yes, so this is a case, you can see that we have some vitreous inside the anterior chamber before we go into the surgery, and of course the lens is also tilted. So the main advantage is that we can customize the rhexis and center it on the nucleus and not on the iris. That is the most important part. So you see that in this case, the rhexis is very well centered on the nucleus so that we can place a lens and centralize it on the bag. So once we do that, of course, this patient required a vitrectomy from the pars plana so that we can stop the egress of vitreous and cut it from the root. See, the rhexis was free floating, and once the rhexis is removed, we can easily put in a CTR. With the CTR, the bag is stabilized. Cortical cleavage is, of course, not a problem with the femto laser. And once that is done, the cortex is removed, and a lens can easily be placed. Of course, it is better to place a 3-piece lens. It is placed inside the bag, it is centralized well, and the patient goes home and is happy the next day. Patient post-op is 6x6 on day 1. So as I can just want to say that as technology is evolving, femto laser is finding its own uses in complex cases. It is time to take the leap of faith and switch to the power of femto. Thank you.
Thank you, Dr. Raghav, for that enlightening talk on use of flax in various situations, especially in posterior polar cataracts, and also in situations where there are zonular weakness cases. So let's open his presentation for discussion for the next 5 minutes. Over to the expert panel. If anybody have anything to comment or take the issue forward.
Yeah.
Yes, Amita.
Can I say something? Yeah.
Yes,
Yeah, good evening, everyone. Excellent presentation, Dr. Raghav.
Thank
So
you.
I've been using flax for the last 5 years now. And yes, definitely in certain cases, it has an edge over our routine phacoemulsification, especially if the patient has already corneal guttate changes where there is a high risk of corneal decompensation. Then definitely I would advise patients to go for flax. Secondly, if there is a very brown cataract, hard dense brown cataract, then these cases also we can attempt to reduce the amount of phaco energy by using flax. However, in cases of small pupil or if there is a corneal opacity, we know that it is difficult. So because of the corneal opacity, the femtolaser will not penetrate. And in case of a small pupil, it is difficult because you will end up having a very small rhexis. So these are two scenarios where flax is not advisable. So definitely, I think in all the other cases where he has explained, we have found that flax has had a very good edge over the routine phacoemulsification.
Also, one thing I did not show in my talk is, of course, how we can use the femto to manage astigmatism also. So
Yes.
of course, that is one, when any conference which has a talk on femto will be speaking on astigmatism management. So we know that we can treat up to a 0.5 diopter of astigmatism with our main incision. But yes, with the newer nomograms we have in the femtolaser, the Tonenfeld nomogram, we can treat an additional 0.75 diopters of astigmatism. So in a sense, we can treat up to 1.25 diopters of astigmatism in a patient. So not requiring a toric lens. So basically, we can help the patient in saving some amount by using that femtolaser. So it gives the surgeon the advantage of course, the premium feel of the surgery and increased safety. And also, we might be able to treat up to 1.25 diopters of astigmatism. And our long-term studies have showed us that this astigmatism treated by the limbal relaxing incision is not coming back.
Dr. Raghav, excellent presentation.
Thank you,
my question is that at present, the biggest limitation of the femtosecond technology is the high cost and additional time. So is there any way companies working to address these two crucial issues, like to reduce the cost of the machine and to reduce or to minimize the time in the OR room?
So again, yes, very good question. So definitely these questions have been with the femtosecond laser since the first day, and they still are looming around the femtosecond laser. Yes, so let me answer it in two ways. Yes, the additional time, I agree, but the trade-off is a safety for the patient. Yes, it depends on what setting the femtosecond laser is in. If you're in a premium second, the patient does not mind those extra 2 minutes. We, of course, don't have the femtosecond laser on the same room as the OR, but yes, it's on the same flow in most of the practices, and that patient does not mind. Rather, the patient has that premium feel. You talk to the patient, you tell the patient that abhi aapka laser hua hai and aapka lens change hai. And I have not had even a single patient complain that why additional time. Secondly, of course, cost is about demand and supply. The more the demand will increase, of course, it is penetrating now. Most of our practice at Center for Sight, I would say majority is now going towards femto lasers. So yes, as more and more practices will start obtaining a femtosecond laser, the prices definitely will go down, sir.
That's good. Thank you.
Yeah, Dr. Malik, any experience?
Yes, Rakesh.
So please unmute, sir. Rakesh, sir.
Hello.
Yes, sir.
Rakesh,
Very excellent presentation, sir. I want to know just if the patient come with the PTS is present in the antechamber. So is it any actually difficulty to make the rhexis by the femto?
Okay, so that was exactly the point to show that video. So that this patient was a post-traumatic subluxation, and there was a vitreous herniation which we could see in the slit lamp on the slit lamp itself. So we know we already had a VR backup. We knew that we had nothing to lose. So this just goes to show that we have done a couple of about 5-6 cases we do every 6 months, that yes, wherein there is a vitreous in the anterior chamber, the femtosecond does penetrate. Like Anaga ma'am said, that we tend to not use femtosecond lasers in case where there is an opacity. But yes, even if there's an opacity,
I've also done it in cases where there was a phakic IOL induced cataract.
Yes. I didn't show that.
A patient had come to me 6 years after phakic IOL, and she had a cataract, very high myope.
Yes.
So we want more safety in these cases. So we have used it in the presence of phakic IOL also. Only thing is, you need to manually make the anterior the surface of the phakic IOL, you need to bring it down to the anterior lens capsule. So just a few changes in the settings, that's all.
because the femto laser
Dr.
gives the optic of the ICL as the pupil.
As the lens of it. So you need to make those changes.
Yeah, Dr. Harsh, please.
Good evening, sir. Thank you for my intervention. Of course, we all know that flax works very well in complicated and complex cataracts, but we've also seen that for the large majority of cataracts, as of date, perhaps flax is not giving us any advantages, plus the cost factor. And we are talking of the reduced phaco energy because the Rex is done by the femto, but femto energy has its own issues, which a lot of trials, especially the Euro trials and all, have told us that with increased rates of CME, and of course that the quality of Rexes is not as strong as with done with let's say a cystitome, or lots of reports are there, or even with the cystitome. So that's all, just wanting to know how that is being tackled.
Okay, so yes, let me answer that, sir. So now, against no financial interest, we are using the Catalyst, and the Catalyst 7.0. What we have done is now that if we have a cataract grade more than 3, the number of repetition cuts of the laser is now being decreased. So even with a single pass of the laser, we can have the same effect that we have with the 4 to 5 laser passes. And that is reducing the femtosecond energy. But yes, you're right. So there were studies, but now because of the advancement and the refinement of the lasers, there is no damage to the endothelium with the femtosecond laser. And the number of cuts has been reduced, which is to answer your question. So yes, the chances of any damage with the femtosecond laser have drastically gone down.
Thank you.
Sir, especially for multifocal lenses and for torics also, the centration that you would get with a femtosecond capsulotomy is much higher, rather than 90% of the cases. All our Rexes are well centered, no doubt, because all are very good surgeons. But there have been times, especially in torics, where a part of the CCC is slightly on the outside and it's not perfectly centered. So you might have a incomplete or imperfect or an inadequate covering of the Rexes of the anterior surface of the lens. So in such cases, we have found that this works much better because it's, consistent and equally placed all around. Yeah, Dr. Arvind was saying something.
Yeah, Dr. Malik, any advantage while making Rexes in pediatric or intumescent cataract?
So yes, sir, but we have not used femtosecond lasers for our pediatric cataracts. I'm being very honest, sir, but yes, definitely there is. I have also read a couple of articles where we could possibly use the femtosecond to make a PCC in a pediatric cataract. So they want to use a femtosecond laser not only to make of course the advantages of a femto laser cataract surgery, but also to use it to make punch holes in the posterior capsule of a pediatric cataract so that we can have a very clean PCC, eliminating the need of a YAG laser. So there is definitely a role, but yes, we have to look at the sizing of the PI, multiple factors. But yes, definitely there's a future there, sir. I've read multiple articles.
Intumescent, yes, we have used very frequently. And the advantage is, especially with the Catalyst platform, it takes just around a second. So
no extension in any of the case?
Yes,
Dr.
no extension.
No, none,
Yes,
none,
no extension.
none.
But remember, this is a postage stamp perforation. So when you actually take him on table, you need to stain with trypan blue. There could be areas of skip areas. So you have to be very careful and then complete it if at all there have been some tags. But 99% of the cases, there is no extension. And I think that gives a great advantage because the chances of Argentinian flag sign reduces significantly.
Exactly.
With that, let's move on to the next speaker. Dr. Madharia, are you ready? Sir, Madharia, sir? Madharia, sir, are you ready? Please unmute yourself. Dr. Madharia? If he has some issues, probably we can move on with Dr. Deepak Megur.
Yeah.
Deepak,
absolutely.
Deepak Megur, he shall be speaking on decomulsification in small pupils.
Good evening, everyone. My topic is on small pupil, and I'll be speaking specifically in relationship with pseudoexfoliation. Am I audible?
Yes, Megur.
So I'll be restricting myself to small pupil in pseudoexfoliation cases, and just take you through a few different case scenarios and how we can do. So we can also remember that in pseudoexfoliation, apart from the pupillary issue, we've got multiple issues to deal with. So because the pseudoexfoliation is deposited all over, including the zonules, the capsule, and the pupillary rough, you expect, apart from dealing with the pupil, the zonular health is also an issue here. So the first always would be to tackle with the poor mydriasis, because the basic principle of any surgery is we need to see well to do well. So these are the situations where invariably you also will be having, dense cataracts. The first option always is to use an intracameral dilating agent, which is going to help in quite a significant number of patients. And especially it helps in prevention of intraoperative meiosis. Even though in many rigid pupils, it may not dilate the pupil very well, but at least it will prevent, intraoperative meiosis. The second, standard which we are using always was to stretch the pupil using Y hooks or Kuglen hooks, which used to produce some micro sphincter tears, which would help to maintain the mydriasis. And third would option be, viscomydriasis. All these works when the pupil is not very small and the pupil is not so rigid. The other, older techniques which we used to use was the microsphincterotomies. Care is to be taken that you don't cut a lot of area in through the rough. If you can minimize it, then you can maintain some amount of cosmetic appearance. It will not be so bad. So if you're careful that how you cut the pupil, it should not be too much into the pupil. But nowadays, most of us are not using this. Apart from this, the disadvantage is you don't get a very wide dilatation of the pupil, but decent enough to manage. But of late, because we have got better ways to manage the small pupil, we are not using the sphincterotomies anymore. The first device which we all started to use was the Irishhooks. Irishhooks were gold standard for quite a long duration of time. A simple reason is the amount of mydriasis which we get is excellent. There is no limit. You can extend it all the way up to the limbus. But at the same time, the disadvantage is if you stretch a lot, you're going to cause a lot of sphincter tears, which are not so cosmetically acceptable to be seen later on. But otherwise, in situations where you want an excellent expansion pupil, there's no alternative to Irishhooks. The other popular devices which we are, of course, using nowadays is the Pupil-based ring devices. And in India, and for me, I use the BX ring more commonly than the Malugin ring, simply because of the reason for affordability. One disadvantage with BX ring is that the profile is so thin that you may not get enough dilation or struggle to insert it in rigid pupils. So that is a case like this. In this case, where that is pseudoexfoliation rigid pupil, I'm stretching the pupil before placing the ring, so that it becomes easy for me to place the ring and it can stretch the pupil a little bit more. When you're dealing with a swollen lens, always it's a good idea to put just a little bit of OVD under the pupil so that it lifts up. We don't damage the anterior capsule. We're trying to manipulate the hook. It's always a good idea to stabilize with the second instrument, especially when doing in topical surgery, so that we can see well and the eye does not move, and then we can engage these notches. There are 3 pairs of notches, and each of them is easily negotiable. That there is no steep learning curve with this. Just do a couple of cases, understand the principles, then you would probably be good enough to manage these cases. Just look at a few cases, that's all it requires. And then you get a decent opening. You cannot say it is extremely wide, about 5.5 millimeter, but for most case scenarios, this would suffice. Predominantly, we would like to use it as a retainer rather than an expander. It prevents the pupil from coming down. So in this case, the zonules are weak, obviously. And in these cases, I always prefer to put in the CTR earlier rather than late. So once I do hydrodissection, create some space within the bag by using some OVD and then thread in the CTR. So my belief is that if you can stabilize the bag before the nucleus management, the chances of prevention of further zonular damage is very much minimized rather than postponing it. So once the bag is stabilized, then the phaco is a routine one. You can choose the nuclear disassembly technique of your choice. See, in this case, we are also taking care of the zonules as well as the pupil. So if you have the concepts right and you attain, you can go step by step, most of these complex cases can be managed well. So again, once the lens is placed with the OVD still inside the chamber, you're going to disengage all the notches and then removing. Removing is the easiest part of the BX ring. That's the advantage, and it's very sphincter friendly. It's another case where we have a dense cataract and a pseudo-exfoliation and non-dilating pupil. These are the cases, the surgery becomes much more simpler once you start to see well. So rather than struggling to be with the, trying to do with a small pupil phaco, I think nowadays we don't have any excuse for not using an expansion device. You can use expansion device of your choice. In this case, it's very rigid. So obviously before putting the BX device, again, I prefer to stretch it, fill the bag with OVD and a little bit OVD under the rexus, not too much, just to lift it up so that the swollen capsule does not get perforated by the your tip of the forceps when you're trying to manipulate these rings. So it just takes, a few seconds to manage and engage all these notches there, and it maintains the pupillary size. So initially in the early part, a few years back, we used to have courses where how to do phaco in small pupils. So we are talking about the plane of emulsification and all those things now, but with the availability of these expansion devices, things have become much more simpler and safer. So the whole idea of using any expansion device is it makes the surgery much more simpler. Most of the people might find it intimidating to use these devices in the early part of their learning curve, but believe me, it is not so. So once you can see, well, the case becomes exactly like a routine one. So there's no surprises, and the safety factor is immensely improved. So the phobia which we have in among surgeons to place these rings shouldn't be there. It just takes a couple of minutes extra from a surgery, but it adds great value as far as the safety is concerned. One unique thing about this BX device is that it's quite sphincter friendly. This is the post-op of after using the sphincter if you're not stretched it. So there's potential limitation. One limitation is the mydriasis which we get is not of great extent, but it is not required for most cases. However, in situations where, in this case, the rexus has extended radially, and in these situations, if I decide to convert or I want to see the edge, these situations where this may not be help enough. So in this case, I would replace it with a ring and then see well and then proceed. So limited mydriasis is an issue, and it is not for routine cases. When you have an intraoperative event, then it becomes a problem. You want to see well. So in my current practice, small pupil management, BX ring is preferred for most case scenarios. However, certain situations demand the use of Irishhooks. Like where we have got a rexus which has gone run off radial, I want to see the peripheral edge, then definitely Irishhook is the one which I go. And second would be a peripheral posterior capsular tear. And it's situations where you're forced to convert to SICS. You cannot go ahead with the BX ring itself, because when you try to tumble the nucleus out, the ring gets disengaged. So this is one case where I have decided to convert, and the BX ring comes out, and you're going to use Irishhooks to ensure that the pupil is very well dilated, and then you can see exactly where the area which has gone radial, and you can place your lens in the bag accordingly. So the other situation where we would avoid using a BX tear is when you have a peripheral PC tear, something like this. So in this case, we are unable to see well. In these situations, if you want to see that particular area, the best way is always to go ahead and use a hook there, so that you can visualize where exactly is the PC tear, and then you can place your haptic well and truly above the area and ensure that you don't end up having any more mishaps. So definitely Irishhooks does have a role even in the modern day cataract surgery, as does your BX rings and other devices as well. So that was it. Thank you for listening. That was it.
Thank you, Dr. Deepak Megur, for that wonderful exposition. I would like to invite the other Deepak, Dr. Deepak Mishra, to initiate the discussion.
Thank you, sir. First of all, wonderful surgery with what a stable hand you have, Megur, sir. But since the pseudo-exfoliation cases usually have low endothelial cell count, so I would like to know some tips from you, how you manage those endothelial cell count, and sometimes it may have a shallow AC too.
Yes.
So what is your tips to use such a rings or other thing with a case of low endothelial count and shallow AC?
Yeah. Thank you, sir. That's an excellent question. I think my mantra for this always is to ensure that we are using a dispersive OVD like viscoat or viscoat-like substance first, which protects the cornea. And there is nothing more expensive than the endothelium. So we shouldn't worry about the cost factor in these situations. Even we have got excellent dispersive OVDs, which are viscoat-like even by Indian companies. They also do the job well. The second most important point is the plane of emulsification, what we do here. It's important that the plane of emulsification has to be much more posterior. So I would ensure that I see well by using any pupil expansion device and try to manage the fragments at the level of the rhexis margin. Even though if it may slow down my procedure a little bit by using a little bit of a low flow rate and vacuum, if you can control the lens chatter and lens turbulence inside the eye, you can definitely minimize the amount of trauma which you can cause to the endothelium. So protecting the endothelium by using the appropriate OVD and a posterior plane of emulsification, they would be my two go-to solutions to deal with this.
Thank you, sir. One more question. Do you find any advantage of doing horizontal chop instead of vertical in such cases?
No, I don't think the nucleus division strategy is not going to much of a situation. Are you talking about endothelial protection or something else? For what?
No, sir. Just for the capsular protection or the zonular weakness point of view.
Yeah, one argument is that if you do a horizontal chop technique, then your stress is not there on the zonules. That's the reason why in zonular weakness, people would recommend that. But if you're careful and if you know how to do a vertical chop or even divide and conquer 4-quadrant technique, that as well. If you know how to do well, most of these techniques are very zonal friendly. Only thing, it depends on the surgeon. You can't blame the technique for it. So all of the techniques work equally well.
Thank you, sir. Thank you.
Can I just have
Yes.
just few inputs here? Excellent presentation, Dr. Deepak, as always. So regarding BX, I've been also using BX. I'm a big fan of this. One thing is, because of its uniplanar profile, it has an advantage, as well as sometimes it could be a little difficult to maneuver it. It can easily slip underneath the iris. Once that happens, you just need to bring it out and then put it back again. If you try to fish for it, you will cause more pigment release. So that is one thing. But because it's very gentle and it has a very soft it doesn't really affect the pupillary sphincter. So even in multifocal IOLs, I've used it with very good results. And in case of Irishhooks, one issue is we just need to be sure where we are taking the side ports, because if you are putting it too anteriorly, then it can cause bunching up towards the cornea, and if it's too posterior, towards the angle. So you just need to be sure where exactly we are putting in the side ports for the Irishhooks. So that's just one small tip.
I want to add something. Now, oftenly we are getting the cases of pseudo exfoliation. I believe daily 2 or 3 cases if you are doing 10 cases. And poor dilatation is the one most very important problem. Besides this, the iris floppy, or you can say the prolapse of the iris from the wound, even from the side ports, is very common. The advantages of hook or any dilating instrument like this, any ring, is to protect the prolapse of iris from the wound, and that is very important. Otherwise, if you handle the iris so many times or badly, so it becomes more prone to prolapse. So this is the main advantage with all the cases of pseudo exfoliation plus poor dilatation. And poor dilatation is in most of cases with the pseudo exfoliation, which may be age related or maybe some drug induced. In both these sexes, now we are seeing the such kind of cases.
In pseudo exfoliation, if the pupil is adequately dilated, maybe flax is also a good option.
Yeah. Even it's your dilatation is half, even you can manage, of course, but even you use it. So even a 1% chance of the iris prolapse and other things, so you can prevent it. It's now
Deepak, sir,
important thing.
What is your choice of intraocular lens in such cases? Is it heparin coated you prefer?
No heparin coated. I'm not using any heparin coated. Most of the cases, the regular hydrophobic lenses will do. The only modification which I do, where if you have a generalized zonular weakness, which is moderate and significant, if you have a floppy bag, then I use a multi-piece hydrophobic lens. The CTR is in the bag, multi-piece hydrophobic haptics are in the bag, and then you achieve an optic capture to avoid a late onset decentration or dislocation of the lens in pseudoexfoliation cases with generalized zonulopathy. Otherwise, the standard hydrophobic lenses is what we use in most cases.
Works well.
So I have one question, sir. First of all, thank you, sir. We've learned so much from your videos, not just today, but of course, so many of your videos. But I have a small question, sir. So in case of a pseudoexfoliation, if your pupil is, let's say, decently dilated, how generous are you in using a CTR? In case, let's say there is no phacodonesis, do you use a CTR?
No, I think, no, CTRs are not used for all cases of pseudoexfoliation. So you know the health of the zonules once we touch the antercapsule.
Yes.
So you're not seeing any phacodonesis in the slit lamp. You're absolutely, but you have pseudoexfoliation.
Yes.
But the health of the zonules is known only when you start puncturing the capsule, once you say the radiating folds, and when you start tearing the capsule. If you're seeing those folds adjacent to the tearing edge when you tear it, that's a sign which indicates that some amount of zonulopathy is already there, which is not detected by slit lamp examination. These are situations where I'm going to use a CTR. Otherwise, no.
Thank you, sir.
Dr. Deepak, have you seen any cases of late onset dislocation of the lens in pseudoexfoliation in your practice?
Many. So I've seen many cases. So initially, that was the idea. What we used to put a CTR and also the lens in the bag, and later on, 8 years, 10 years down the lane, everything goes down. That is the thing. So I've seen
Sometimes even any tribal trauma can also lead to
a bit of even forceful rubbing and all those things.
Yes. So that's why it's very important to explain these cases to be in regular follow-up and to to come to ophthalmologist even after successful surgery to get the follow-up examination done for not only for the late onset complications like phimosis and dislocation, but also for glaucoma as well.
So it's a lifelong patient for us.
Yes,
Pseudoexfoliation is a lifelong patient. Glaucoma is a very common association.
Yes, thank you.
With that, let's move on to our next speaker, Dr. Lakesh Madharia. Sir, are you ready with your video presentation on traumatic cataracts? You may be having some technical difficulties. Madharia, sir, are you ready? Otherwise, okay.
Sir, you need to open your presentation.
Yes, sir. That is the presentation. Please click it. Third one from the top. Third one from the top, sir, on your screen, on the right side. Madharia, sir, I think you have already opened the video. You just go to the tray. 2 programs are open.
So you can play it actually.
Okay.
Sir, is it audible, sir?
No,
Yes, sir,
we are
it's
not
audible.
able to see. We are not able to see.
Not able.
Just reshare now again, please.
Yeah, please reshare.
Share करो please. Wait.
So, Dr. Madaria, first open your video, pause it, then share, please.
Right, sir. Now it is open, sir.
And now share. First, keep your video ready, then share. Now share, please.
Madaria sir, I think we will move on with the next speaker.
Yes, sir.
Open your video and then you restore size.
Open the video.
So let's try one last time. First, open your video, pause it, then do the share. Please don't open your.
Okay, sir. Video chalao. Now is it able?
Yes, you can play, please.
Dr. Madaria's video presentation is on traumatic cataracts.
Good evening, all the dignitaries. This is a phaco in traumatic cataract video presentation. This is a traumatic cataract. A 10 years old boy. He had corneal tear, and it was repaired somewhere else 2 months back. Then the patient comes to me with a raised intraocular tension. Here we can see a very swollen traumatic cataract with the stitches in the cornea. For staining, we have injected the air. After injection of the air, we put the dye refined blue. After injecting the dye, after 8 seconds, we wait for the 8 seconds. Then we put the high molecular viscoelastics. Now we can see the anterior capsule is torn from 1 o'clock to the 6 o'clock. And there is again a tear at the site of the injury where the stitches are applied. So almost the anterior capsule is irregularly teared. Now we are, with the help of 26 case, then we are trying to make as much as round capsular axis we can make, because it is a very much irregular, and anytime anything can happen. It can extend. We have made a small cut with a small capsulotomy scissor, and with the help of microcapsular axis, now we will try to make the capsular axis. Yes, we can make it up to this level. Then for the further is yes, it has extended up to the periphery. This is the very bad scene which we do not want to occur, but it has happened. Now nothing we can do in anything can happen in traumatic cataract. Now the other part also we are making a small nick, and is already, yeah. This now we can see the loose cortex, because this is a 10 years old child, so there is no nucleus. So no ultrasound will required. Now that whatever the loose cortex is there, we are trying to remove it. It is coming through the opening of main incision. Now we will try to remove the cortical matter with the irrigation and aspiration by manual. Whatever cortex which is visible, we can see. I think that we can see that posterior capsule is also a little torn. But let us first, with the bimanual, we try to remove as much as the cortical matter we can remove. And with the help of bimanual, almost 1/3 of the cortical matter we are able to remove. Now on this side at 9 o'clock, as soon as we are removing it, now now as our rexis was extended up to the periphery, now the PC rent has taken place. Yes, the PC rent has taken place. The vitreous is started coming. Now we will put the viscot and we will try to push the vitreous back as much as possible. But we need the vitrectomy. We are using this Centurion anterior vitrectomy, as the vitrectomy cutter is very high in Centurion. It is 5,000 cuts. So I will use that 5,000 cuts vitrectomy. We are after pushing the vitreous back by the viscot, we are trying to remove some of the cortical matter if as much as it is possible. But I think beyond that it is not possible. So that vitrectomy is loose cortex is still floating in the anterior chamber. Now we are doing the anterior vitrectomy. First, I am doing the dry vitrectomy. Here we have the AFR, we have kept 25, and this vitrectomy cutter is 5,000 cuts, and vacuum is 500. As because of the high speed of the cut, at this vacuum also we can do a very good anterior vitrectomy. We can see almost all the vitreous we are able to cut. Then still there is a cortical matter also. So there is a setting in the Centurion vitrectomy where we can do the epinucleus and the vitrectomy, both we can cut. That is a epivitrectomy, epicut. So to remove that cortical matter also, now because this in the upper part at 2 and 3 o'clock and at the 9 o'clock, cortical matters are there. So with epivit, now this epinucleus of this cortical matter, loose cortical matter, we can also remove with this second setting of epivit. Now we can see up to some extent the slight reddish glow we can see up to some extent. And after this almost the cortex from the upper part of it has been cleaned completely, except in this 9 o'clock, some cortical matter is left. But as vitreous has retracted back, we have almost done the majority of the vitreous removed. So some cortical matter which is left at 9 o'clock, we are able to remove with the bimanual again. Yes, almost all the cortical matter at 9 o'clock, it has been removed. Now we can see that there is a synechia of the from 2 o'clock up to the 5 o'clock. There is synechia. To insert the 3-piece Elcon IOL to place the haptic leading haptic, we have made we are making a space between the iris and the anterior capsule too. Now we can place the 3-piece Elcon lens. Still some amount of adhesion is there at the traumatic area, which is a fibrous band is there. Now I am cutting that fibrous band, so haptic can be placed properly. Now we can see some red globe. We can see, I think because of the PC rent, some dye has gone into the vitreous also. So the absolute red globe as we want, we are unable to see. Now, yes, this place I am able to make to place the leading haptic. Yes. There is again synechia is there. Now I have broken all the synechias. Now this 3-piece Elcon lens is ready. The loading is very important in 3-piece because trailing haptic should be properly loaded. Otherwise, there is problem in unfolding. So as because of the vitrectomy, the eye is almost very soft. In spite of putting the viscot, the eye is very soft. So now, yes. Now, at 3 o'clock, I will put the leading haptic. Yes, the leading haptic is going. Yes, it is unfolding and it has gone. Yes, now it has reached to the 3 o'clock. Now the trailing haptic has to be put on this side, 9 o'clock. So I am dialing the optic. Yes. And that trailing haptic has been put in 9 o'clock. So this is the I am little constricting the iris. So it can be placed in the sulcus. And I'm trying to remove that the corneal stitch. It is almost healed. So I have removed it. Though yes, with these we are able to put the 3-piece lenses. Thank you very much.
Thank you, Dr. Madaria, sir.
Sir, thank you, sir.
For that wonderful video. I open it up to the expert panel for further discussion.
Very well managed case, sir. In such
Pardon,
type
sir?
of case, very well managed case, sir. Can you hear me?
Yes, sir. Yes, sir. It was a very bad case, sir. Very bad case. Tension was raised. And already, I think there was a small, already perforation of the PC dent was already existing there.
Yeah, that's why the dye went down. And then
Yeah, yes, sir. It has gone down.
Yeah.
That's why the red globe was not very much perfect to see all the time.
Yeah, that makes surgery further difficult in such kind of cases. So in such type of cases, we first need salvage as much regular rexes we can make out.
Sir.
And then proper vitrectomy, that is very important. And you absolutely use very high cut rate. That is also very important.
Sir.
So very well managed case.
Thank you, sir.
Sir, I want to ask you that maybe use of intracameral triamcinolone may be helpful in such cases to stain the vitreous and to minimize inflammation.
Yeah. Actually, sir, after the end of surgery, we find that pupil was almost round and circular. If there is any trace of vitreous is present there, so the chances of irregular iris is there. Of course, we should do that for the 100% confirmation whether any trace of vitreous is there or not. Triamcinolone at the last of the surgery, we must do it, sir.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, Dr. Madaria. Congratulations for struggling a lot with such kind of very complicated cases.
Right.
And such kind of cases gives us very good opportunity also to learn so many things. And there are so many things to still do. The first thing is the very important that one should do a very proper slit lamp pre-op examination. That where is the tear and how is the anterior capsular tear, what is the wound gap and synechias, as you faced a problem at every step.
Actually, sir, the patient came in agony of pain and there was rest tension also. You can see in the beginning, the cornea was hazy.
Yes. We can understand all the
we cannot wait
are there
for little longer time.
Yes. And second thing, we keep everything in the mind.
Sir.
Or we enlist every expected complications beforehand. That this can also occur, this can also occur, this can also occur. So this create a good awareness in our mind. So if you are well aware, so you can prevent a lot of the complications.
Right, sir, right.
And really, you have managed very well. And I want to do something, add something, tell something that you can aspirate some lens matter before extending or making the capsular axis to some more extent. So what happens? The intralenticular pressure comes down. So it becomes a bit easier to make a good rexis. Otherwise, your start of the rexis was very nice. So just to prevent some extension, even though it can occur, we know it. But if we decrease some kind of amount of the intralenticular pressure, so it can give maybe a good chance to prevent the posterior capsule here, and really it's wonderful.
Right, right, sir. Good suggestion, sir. Good suggestion. Thank you, sir.
With that, let's move on to our next presentation. The speaker is Dr. Harshvardhan Gupta from Om Netra Kendra, Raipur. He shall be speaking about management of Argentinian sign in white cataracts. Over to you, Dr. Harsh.
Thank you, sir. I'll just be showing a few videos which are edited, and just a moment, I'll just call my. Just give me a moment, sir.
Good हो गया ना? Good हो गया.
Share screen कर दिया?
Mathur sir.
Yes. I'm ready.
Yeah,
Yes.
Because what happens, sir? This is the problem creating all the time for everyone. So why not in the next time or any webinar, 1 hour before, everybody will load that their videos or their presentation 1 hour before. So at the time, it can be nicely presented in due course of time.
Right.
I have wasted some time, somebody's. So it is my suggestion. If it is
Generally, we
possible.
log in 15 minutes earlier, sir. Whoever is want to check out their videos and presentations, they can do so.
Sir,
Generally,
right.
we log in 15 minutes earlier. We will
Right.
suggest to Santosh, let's log in at least 20 minutes earlier to the next webinar.
Yeah, right.
Yeah, I'm ready to start. So very sorry for the delay. Actually,
Yes, Dr. Harsh, you can please.
yeah,
proceed.
just a few short videos where we all are white cataracts. A couple of videos where we've had a extension, and we managed to complete the surgery with phaco only. This is the first case. This is the white cataract.
But there is no presentation.
Not able to see your presentation.
You can't?
No. You please start sharing your screen.
Share.
Pause your videos. You first pause your video and start sharing the screen.
शेयर करना है यहाँ पे
वीडियो पॉज कर दीजिए पहले.
Dr. Harshvardhan, on the Zoom window, there is a green button.
Yes, I've shared it at the one side, outside only, but I don't know.
Now we are able to see your screen. Yeah, now you play.
Yeah. Up for the big screen. Is it okay now, sir?
Yes, sir. Yes, sir. You are able to see. You can start.
White cataract, and we're just starting the rexes, of course, and you can see the milky fluid coming out, and I'm just aspirating some of the milky fluid to reduce the interlenticular pressure to avoid rexal extension. But as we are moving, Now here I'm having a little difficulty, and it appears that the rexis is extending, and I can see that the rexis is now extending. Has extended, and we have an Argentine flag sign. I've just opened from the main port. I like to do it from the main port, although there are some advice that it should be done from the rexis port only. And now I'm trying to complete the rexis with a rexis forceps, and we can see that the rexis is now complete. The extended rexis. It is not a perfect curvilinear rexis, and we are proceeding with the surgery. And this is same case. You have to go. Yeah. Going to the next case. Because the videos have been edited, we have not shown the completion of the surgeries, just how we have managed. Here the rexis is going fine till now, and don't seem to have any much of a problem. But now we see that again there is a tendency for the rexis to go out. It's always safer to change than to a rexis forceps. I usually do all my rexis with the cystitome only. Very rarely use the rexis forceps. Here again I am stuck, so using the vanas to again cut the rexis margin there so as to complete the rexis and then proceed with the case. Of course, it's not a pretty looking rexis, but we can see that we are able to manage a clean phacosurgery, and the lens is being implanted and without any mishap. So one more case. The purpose of this talk is to tell the beginning surgeons that we need not abandon the phacosurgery when you have a rexis extension. You can manage it. You have to just keep your cool. And as these are all things are self-explanatory, so I'm not giving too much of running commentary. Here we are having a rexis. Rexis is going. All the cases that I'm showing, we have had rexis extension in all those cases. There are a little older videos, so clarity may be a little problem because nowadays the number of white cataracts that we see in nowadays practice is very less. Here, because again I'm stuck, I filled the viscoelastic again to form the chamber, and then again we are using the first the vanas to make a single cut, and then we have gone to complete the rexis. It's a sort of eccentric rexis. We don't have a central rexis. So first, it's more important that to complete the phaco and not to extend and convert. So this is the case post-op immediately after surgery. It's a neat and clean surgery, and the surgeries. There's one more case. This is the last case that I'll be showing. They're very short edited videos. Here again, we are starting the rexis. From problems of wide and hard cataracts, now we are quite some time now we are having problems with the softer cataracts. We've made the main port incision because I'm not being able to complete the rexis. So again, I'm just moving to the main port, filling the chamber with viscoelastic, using the forceps to complete the rexis as best as I can. At the first instance where you think the rexis may be extending, and this is the end of the surgery, and so that's a smooth and clean surgery. Yeah, thank you. Thank you.
Thank you, Dr. Harshvardhan, for your presentation of Argentinian flag sign in various cases. His presentation is open for expert panel discussion.
Thank you, Dr. Harshvardhan, sir. Sir, which viscoelastic did you use in managing such cases of white cataract?
Generally, when I use mostly all my cases of white cataracts, I use sodium hyaluronate. But if there is a problem with the cornea, then we go to viscoat.
Okay,
so Grexis, we don't use HPMC for a very, very long time now. And even routinely, all the premium cases, we don't use HPMC for Rexis in any cases.
Okay, sir. So use of the viscoelastic is very important in such cases of white cataract, and once you use combination of sodium hyaluronate and pontotic sulfate or sodium hyaluronate, so that we can counter the positive intralentricular pressure with the viscoelastic.
Absolutely.
Thank you.
Also, we can make a first nick very large enough. So that will decompensate the pressure. Intralentricular pressure will be regressed. And then we can make a small rexus, and later on we can enlarge it.
Yes, of course. And
so
as
that will,
we can aspirate some of the milky
to
decompress the back, because this is something which is waiting to happen. So,
if you have noted one thing, that in all the cases, the extension has occurred in the sub-incisional area.
Yes.
Yeah. No. So, how to counter it?
then we can make an entry from the main incision, and we can use microcapsular access forceps, intermittently holding at 1 clock hour again and again. That gives better control.
You also need to inject the high molecular weight viscoelastic
Definitely.
intermittently.
Exactly.
Don't allow
Definitely.
the chamber to shallow, and I prefer to use the side port rather than the main incision. Because when we are using the main incision, inadvertently there could be a pressure on the posterior lip which can cause egress of the viscoelastic outside, causing shallowing, and then that precipitates the tear. So using the side port will help to keep the main incision closed. That helps to maintain the chamber stability. So that could reduce the chances of the risk of anterior capsular tear.
I prefer the main port, but yes, we were putting viscoelastic again and again, and of course shifting to the rexus forceps to complete.
Even putting viscoelastic should not be in the center. It should be at the periphery, so that we don't, if you put it in the center, then it would again increase the tear. So it has to be just peripheral to the point where it is trying to go out.
Exactly. We have to put the rexus flaps down so that we can handle them more easily.
I always prefer to do a smaller rexus rather than a bigger one or an adequate sized one, so that later on, even after putting in the lens, we can go ahead and increase and extend the capsular size, capsulotomy size. Excellent presentation, sir. Excellent video.
Good collection of videos. Okay. If there are no more questions, let's move on to our next speaker. Is Dr. Rakesh Sakhya from Chitrakoot, Sadguru Netralaya Chikitsalaya. He is a head of HOD of glaucoma services, but he is more known as a rocket surgeon. But today he is going to present his presentation on zonular weakness. How fast can you go, Rakesh?
So my screen is visible?
Yeah, yeah.
So good evening to all, sir, especially Mathur sir and Arvind sir and Navar sir and all chairperson to give the opportunity. So all things actually discussed previously well, nicely. So I'm just remind you in my few cases, because I am going to just demonstrate the mild to moderate cases. Now is the video is running?
No. We are able to see your screen. Yes, now we are able to see the title slide. Yes.
About the anatomy of the jonular fiber that originate from the basal lamina of non-pigment epithelium of ciliary body and insert into the lens capsule at the equator region. These fibers play an important role in the lens stability. Its weakness results in alteration of the lens stability. Jonular dialysis may be existing and brought into existence by the operating surgeon. Jonular compromise complicates every step of the surgery. Beginner faced serious challenges in terms of safety and visual outcome. The detection of the jonular dialysis at the earliest remains the crucial point, which determines the subsequent management and final outcome of the surgery. I am going to demonstrate to manage various degrees of jonular dialysis with the use of CTR in very simple two-Sinskey technique. CTR has two holes at each end. One end is inserted from the side port, so this leading end has to be engaged underneath the anterior capsule rim and gradually push the CTR with the help of McPherson forceps. So I take help of the both hands. Now, when I have reached the trailing end, I take Sinskey in my left hand and push through the left side port. Then insert the trailing end with the help of another Sinskey in my right hand. At this time, the left hand Sinskey hook always behind the CTR, and you can see how two Sinskey hook guide the CTR. Sometimes during the insertion of the CTR, trailing edge get released in the angle and become difficult to retrieve. In the process of retrieving of the CTR, it can cause iris trauma, bleeding, and DM detachment. This was a 75-year-old female had hypernature cataract with jonular dialysis more than 4 o'clock hour, a temporal clear corneal echo with foldable and was planned for this patient. Anterior lens capsule is stand by the minimal use of triple blue to improve the visibility of the rhexis margin. 5.5 mm rhexis was fashioned, which is desirable size for the hard cataract. Hydrodissection not required. In this case, the capsular bag was stabilized by two capsular hooks placed in the area and emulsification was done. So in this, I implanted CTR with the help of injector. I was noticed small PCR during IA without vitreous disturbance. So I implanted intraocular lens in the bag. Post-operative lens was centered with BCBA 6Y9. This was a case of traumatic subluxation more than 6 o'clock hour. I have planned clear corneal phaco with sioneering. Capsular access may be challenging due to absence of countertraction. After initial capsule tear with cystitome, I always apply shearing force with Atrata forceps toward the interjoinal to make circular access. Gentle hydrodissection done at multiple sites. Now capsular bag was stabilized by 3 capsular hooks placed in the area of jonular dialysis. After that, rotation of lens became very easy and emulsification was done by modified stop and chop technique. After conjunctival peritome, a small scleral groove made 3 mm away from the limbus. Sione ring now used. This ring has additional suturing eyelet for scleral fixation. A 10-0 rolling double arm suture is passed through the eyelid for the scleral fixation. And Sione ring is introduced through the side port or main port and implanted into capsular bag with the help of McPherson and Sinskey hook. Ensure first eyelid goes into the capsular bag and rest of the ring gently dive. Then 26 gauge needle is passed through the scleral bed about 2 mm away from the limbus. Rolling suture needle adopting into it at the pupillary center. Then needle with suture brought out through the scleral bed. Similarly, another needle with suture also brought out in the same way but placed 1 mm away from the first site. Ends of the rolling suture now tied together and secure the ring with the sclera by 7-8 knots. Now Sioni ring and capsular bag well centered. Intraocular lens implantation was done.
Voice is not coming.
There's some transmission difficulties. We are
Video
not
is
able
stuck,
to-
I think. Video is
Yeah,
stuck.
yeah, video is stuck and the resolution was not good earlier. Rakesh, you please proceed now.
Okay, just a minute.
Yeah.
Stop sharing. I think share again. I think video is not running properly.
Even it is not running smoothly.
So actually, this is the case of serious exfoliation with actually hard cataract. So initially, I always actually after the capsular access, I always put the CTR in this type of cases, and then we crack the nucleus in the 2 half in the both side, and then emulsify it, and then put the IL. So, but during the IA, actually you should be very careful because the journal weakness is even after putting the CTR, journal weakness is there. So by this reason, you are always should be keep in mind, just retract the some part of the iris and then remove the cortex slightly gently. So in this type of cases, initially.
Dialysis can be challenging situation for even the most experienced surgeon. So everyone should
So thank you so much, sir. Actually, I think the video is not running properly.
The video was not running properly and there were some resolution issues also.
Okay.
Anyway, thank you, Rakesh, for your presentation.
I don't know. Actually, I'm in the hotel room, but I don't know what happened.
Over to the expert panel. Dr. Anand Saxena, if you have any comments?
Stop sharing.
Yeah. Yes, Anaga, you can.
Yeah. I think Dr. Anand was saying something.
No. Go ahead, madam.
Yeah. Excellent videos, Dr. Shakya. He's a brave surgeon and absolutely fantastic surgeon. I think many of us and many surgeons may not be able to even go up to whatever his level is. But definitely, I think in more than 4 clock hours of subluxation, first thing is we need to ensure that there is no vitreous there, especially in case of traumatic cataract. If there is vitreous, then we need to ensure that that is removed first. Check along with by using diluted tricot, and then go ahead with the surgery. Number 2 is whenever there is a very severe subluxation, basically there are 2 ways of doing it. If it is too severe and if it is beyond managing or being able to salvage the capsular bag, then maybe doing a pars plana lensectomy and putting in either a glued IOL, etc. would be one option. But if it is possible, then definitely I think we should salvage the capsular bag, use a CTR with CTS or a modified Sionis ring where you can actually tie it up to the scleral wall and then go ahead. So I think that makes a big difference so that there is less vitreous prolapse and less risk to the posterior segment.
Despite of actually when we actually notice the very profound journalar weakness, the generalized weakness, so we always sometimes we can remove the nucleus and go for the second IL always. This type of cases.
It's always a treat to watch your great skilled surgical videos, rocket surgeon. And such a hard cataract, the cumulative dissipation of energy was 25. So really amazing. Great surgical skills.
Thank you, sir.
Dr. Rakesh, excellent surgery. Do you have a chance to use the ASIA capsular anchor to manage such cases?
No, sir. I don't have any experience this time.
Okay.
Sir, where it is available means, is it available?
It's from Hanita company.
Okay.
Yes.
Okay, thank you. Thank you for the information.
Dr. Anand, you were saying something that time?
Nothing special. Of course, the quality of video was not very good, but in spite of that, we are able to understand the philosophy and the principles of managing such kind of cases, especially the proper use of the intracapsular hook. It is a capsule holding hooks are used very properly in proper places, which can manage the any further subluxation of the cataract at that particular place. And then in the last, he put the capsular CTRA. That's very good.
Actually, sir, in the subluxated cataract, we always start the access with the off center from the jonular dialysis area, and then after that we put the capsular hook.
Yes.
So,
very good.
thank you, sir.
I don't see the last speaker on the screen, Dr. Santosh Singh Patel. I think he has not logged in. Any of the panel experts, if you want to discuss any other point for a few minutes, we can.
Kudos to you, Dr. Manoj sir, Dr. Santosh Anawar sir, and Dr. Harvansh Lal sir for bringing about such beautiful webinars and touching upon such important aspects of complicated cataract surgeries. I think this will go a long way for all the viewers and the youngsters especially to handle such complex situations. So thank you very much for inviting us here and making us a part of this great webinar. Thank you.
Thank you very much.
Your expert tips are always actually beneficial for us, actually.
Thank you for the expert comments, and thank you Santosh Bhai, and thank you Dr. Manoj sir for having us.
On behalf of the AIOS headquarters, it is my proud privilege to propose a vote of thanks. My sincere thanks at the outset go to the expert panel, Dr. Suresh, Dr. Deepak Mishra, Dr. Anada Herur, and Dr. Arvind Kumar Moria, and to all the 5 speakers of the day, Dr. Raghav Malik, Dr. Harshvardhan Gupta, Dr. L.C. Madharia sir, Dr. Rakesh Sakhya, and Dr. Deepak Nagur for their wonderful presentations. And my thanks to my co-moderators, Dr. Santosh Hunawar and Dr. Anand Saxena. Thank you all. Thank you very much.
Thank you, sir.
Thank you very much,
Thank you,
sir.
sir.
Thank you, sir.
Thank you all.
Good night.